Hello, and we welcome you to our sixth Thoracic Surgery Clinics podcast. Published for over 30 years, Thoracic Surgery Clinics is a quarterly publication consisting of review articles devoted to a central topic important to general thoracic surgeons. The series and the podcast can be found at www.thoracic.theclinics.com. I'm John Vasallo, the managing editor for the series here at Elsevier, and for our sixth podcast, we'll be discussing selected articles from the May 2023 issue on controversies in thoracic surgery. As the editors state in the preface to their issue, although much has changed in thoracic surgery over the years, many of the same vexing questions remain. The nature of surgical care makes it difficult to generate level 1 evidence, and in many cases mandates surgeons to rely on systematic retrospective reviews and expert opinions to make treatment and planning decisions. Here to discuss these reviews and expert opinions from this issue are the guest editors, Dr. Lana Schumacher, Director of Robotic Thoracic Surgery in the Department of Surgery at Massachusetts General Hospital in Boston, Massachusetts, and Dr. David Griffin, thoracic surgeon from Intermountain Healthcare in Murray, Utah. Leading the discussion will be our consulting editor of Thoracic Surgery Clinics, Dr. Virginia Lytle, Chief of Thoracic Surgery at St. Elizabeth's Medical Center in Brighton, Massachusetts. Welcome to all three of you, and over to you, Dr. Lytle.
Thank you, John, and welcome, Dave and Lana. Thank you very much for taking the time to participate in this podcast today. So I selected several topics from the issue that you guest edited, and I'll remind our audience that you selected the topics and invited the authors, gave suggestions for the authors. So thank you very much for taking the time to do that and to read their contributions. But I selected several topics from the issue, and we'd like to hear your opinions about some of the contributors' content and offer your own professional opinions on some of the areas as well. So before we get started with the questions, I thought it might be nice to hear a little bit about each of your backgrounds. Dr. Schumacher, you're considered a robotic expert and travel around the country proctoring people and having a very busy robot practice. And Dr. Griffin, you are, I would call an esophageal expert, but of course you practice general thoracic surgery. So I'd like to hear how you both got interested in thoracic surgery and then developed your focus in your arenas. Start with you, Dr. Schumacher.
Yeah, so I was first introduced to thoracic surgery as a medical student, and I actually had the good fortune of rotating on Dr. Valerie Ruch's service at Memorial Sloan Kettering Cancer Center, and it was just a very eye-opening experience. I was very enamored and fascinated, one, with the anatomy, the disease process, opportunity to really cure and just understand kind of the complexities of the cardiopulmonary physiology. And so since that initial experience, and that was a long time ago when we were doing mostly open thoracotomies and just a little bit of VATS, and I've seen it change through the transition, through the many years of training and whatnot, and to develop now into most of our approaches being done robotic. So it's been a great change of the paradigm of surgery. I think it's, patients are having excellent outcomes, being able to perform surgeries minimally invasive, getting them back to their quality of life, and being able to really, cure cancers is why most of us are here. And so that's what really has sparked my interest in my career. And I think that the technology now that we're adding robotics into this, and I think it will continue to evolve as our technology and through artificial intelligence and different avenues changes, we can continue to add to our platform. So I think it's a great platform to keep up with the changes in time and to get better patient care. So that's a short answer of where I'm at.
That sounds great. And Dr. Griffin, can you tell us how you got interested in your, I'd say you're an esophageal expert, although you practice everything in general thoracic. And you could also comment, you also are a pectus expert too. Maybe you can comment on how you developed those foci.
I am a general thoracic surgeon that kind of fell into it a little late. I rotated as a fourth year a fourth year resident coming out of the lab with a gentleman here in Salt Lake by the name of Mike Collins, who had been the only dedicated general thoracic surgeon in our area many years ago. I actually remember interviewing at surgery residencies and interviewing with a general thoracic surgeon going, gee, why wouldn't you do cardiac? And really didn't have a ton of exposure until I rotated with Mike. And truth be told, I realized that many of the same things that Lana was talking about are quite true. And Mike really did not have much interest in minimally invasive approaches. This is long enough that it still was somewhat novel. And I realized that my mentors that had taught me a lot of esophageal surgery I could incorporate those things. And truth be told, I ended up in Pittsburgh, and I learned a lot from my co-editor here, who I still contend to this day is the reason why I can do a VATS lobe. I am not as big a robot proponent, although I certainly espouse minimally invasive surgery wherever possible. And I think that's true of whatever platform. But I had the opportunity to come back here, and I have been here for about a decade and have worked to really develop an esophageal practice where we are.
Dr. Schumacher, I'd like you to address this one. You invited Drs. Lazaro and Inra to write about tracheobronchoplasty, and they also included a nice video of the procedure. So for those who are looking at our issue, as a robot expert and someone who works at a hospital rich with Drs. Grillo and Matissen's history of tracheal surgery, would you please comment on the pros and cons of a robotic versus an open approach to this palliative procedure?
Yeah, it's been great. We've started our program that was added to the program, the robotic approach at MGH. But when I got there, I worked with Dr. Wright, Dr. Cameron Wright, who had been doing them open and really taken over for Dr. Grillo and Dr. Matissen, and has had excellent results. And I trained him in robotics, and we discussed doing the robotic tracheobronchoplasty procedure, and made it a point to go see Dr. Rich Lazaro and see how it's done. And it was great. I had seen his videos, but not worked with him live. And he taught us, the procedure, a complicated procedure with definitely lots of, technical pearls that really need to be emphasized. But when, we both saw the exposure of the left main stem bronchus when you do this procedure robotic, we felt that this is, we've never been seen better before. And, with working with Dr. Wright, who has done so many of these and also a pioneer in this procedure, was very impressed. And so when we started doing them at MGH, I mean, he was thrilled with what we could see compared to what we could do open, and as was I. So we really thought, given the fact that you're minimizing a thoracotomy on this procedure and being able to expose and see better was a huge advantage to really be able to focus on the precision and the technical demands of this procedure. I will say that, and the patients do quite well. Looking at especially, Dr. Lazaro's initial series of having, improved PFTs, but more importantly, the quality of life scores are high. The St. George's Respiratory Questionnaire scores are really good, as well as the Karnofsky scores, all statistically significant. So, and then we brought this over in our own hands and have been really happy with the results as well. But I will say, having done robotics as long as I have, it is not a beginner case. And, I think that Dr. Lazaro really focused on, we need to make sure that this procedure is one that we have a kind of a multi-institution TBM patient registry, so we could really analyze outcomes and make sure that it's done across the board, with excellent outcomes. And I completely agree with that, because if you're throwing these sutures and you throw over, anywhere from 60 to 80 sutures, it's exhausting, it's tiring. There's a lot of technical demand on the absolute precision of each suture thrown. And I don't think you can underappreciate the importance of that. So I think that that's really important to focus on. And I think that that's the goal of Dr. Lazaro. And I think that's the goal of all of us to create this registry and work together to make sure that this gets trained properly.
So when you do the cases with Dr. Wright, do you kind of each sit at a console and take turns because it is so mentally challenging?
Yeah. Since he's hasn't been doing robotics as long, he prefers I throw most of the sutures, and he'll come and throw some. But I really appreciate his expertise and his knowledge base of having all the tracheal surgery that's been done, and the precision and how it should technically appear. And so I appreciate him just coming in even and just saying, okay, yeah, this should be a little tighter, or that maybe that mesh should be a little smaller, or whatnot. I think it's valuable to have that experience. So I'm fortunate to have that.
Great. Thank you. All right. Moving on to another question. This is with regards to the esophageal perforation contribution by Dr. Stephanie Worrell and Kelly Fairbairn in Arizona. I think Kelly was training with Dr. Worrell, so she's not there anymore. But they reviewed stenting and use of VAC dressings, and then they comment on operative intervention. So we classify the first two options as non-operative management. The title of their chapter was Esophageal Perforation, Is Surgery Still Necessary? So I think most of us do these procedures in the operating room, but regardless, it's not a major operation. So they list criteria for non-operative management. And Dave, I'd like you to comment on Dr. Griffin, some of these things. They list the criteria to include a delay in management less than 24 hours. How would you consider this temporal criterion, and would you perhaps consider it a more relative criterion? And secondly, they recommend close surveillance by an expert esophageal team. Such team may not always be available. So what would you recommend for our listeners who are in communities for the best way for them to manage these patients? So two questions. One about the criteria and one about the management in the community hospitals.
Well, I think the 24 hours is, I enjoyed this article. I think the 24 hours is, I think, somewhat of a shifting target. It always, we look at the Pittsburgh Severity Score, we look at clinical indicators, and, some of that may date back to the notion that you never let the sun set on an empyema, regardless of the cause. And we will often typically take these patients pretty urgently because a delay of 12 to 24 hours can be significant with these patients with mediastinitis. And we struggle with this where I am just simply because we are kind of isolated geographically from a lot of our perforations and things like that. We see folks for about a 500-mile radius, and it is not uncommon for 12 to 24 hours to be a standard delay before we get. There are several articles that suggest that even primary repair of a perforation is still quite feasible after this, but I think it really comes down to just how sick your patient is. And nothing beats looking at the patient and trying to understand the nuances of clinical care that come from looking at a CAT scan, and trying to figure out just how sick folks are. And certainly there is a ideal degree of illness for each of the approaches. There are certainly folks that are hemodynamically unstable and just need source control as best you can. And that may be a hybrid approach of stenting or chest tubes. And you honestly have to be somewhat stable to go to the operating room for direct repair. I was joking earlier. I spent last night fixing several perforations, and I stented one that was about 36 hours old, and she had no evidence of mediastinitis. She was rock stable clinically, and there was no pleural effusion. So I felt like that was very clearly the correct thing for her to do, and she is now extubated and looks like a rose today without evidence of ongoing infection. The other question about close surveillance by an expert esophageal team is, I think, a little bit more nuanced and more challenging, particularly depending on where you are in the country. It depends on how sophisticated your colleagues from gastroenterology are, how comfortable they are with stenting, how comfortable you are with stenting. I think most of us have some experience with endoluminal therapy with VAC therapy for leaks and such. But I think we generally kind of fall into those stent or operation type approaches. And although we like to think one size often fits things, and I realize my bias as a surgeon, but very often these non-operative managements have effectively rendered us out of the operating room, even if they are done in the operating room. So I think it's understanding your resources in your community, and certainly having a low threshold to transfer to a higher level of care if these resources aren't there. I think most of us are fortunate that we have all those resources, but I do think that it is an opportunity for surgeons as they develop new practices to be the esophageal experts and work on adding capabilities at their hospitals. So I think there's some good opportunities there, but from my standpoint, like I said, it really comes down to seeing how sick the patient is, what your available capabilities are, and understanding limitations, if any.
All right. Next, we have another esophageal question, and this is with regards to the piece that Dr. Schumacher wrote with Dr. Panda on surgical approach to esophagectomy after Checkmate 577. So basically, this was with regards to lymphadenectomy. But firstly, can Dr. Griffin or Dr. Schumacher remind the audience of the details of Checkmate 577?
So it was a phase 3 randomized double-blind placebo-controlled trial looking at adjuvant immunotherapy following resected locally advanced esophageal cancer. It really kind of, to quote Dr. Schumacher here, it marked the transition of immunotherapy from the advanced to curative paradigm. And while we haven't gotten towards neoadjuvant immunotherapy for esophageal cancer, it really has revolutionized, it essentially doubled overall disease survival for the resected patients in the cohort. And I think it doubled it to 22 months, if I remember correctly. Has been a fabulous addition to the treatment paradigm. One of the things that we struggle with as surgeons, and I think debate has been going on for at least as long as, it predates me, is the discussion about approach. And there are advocates of 2-field, 3-field. There are advocates of transhiatal esophagectomies. There are advocates of en bloc lymphadenectomy. There are advocates of radical lymphadenectomy, and there are minimalists. And it has been one of the challenges about esophageal cancer care as we work to try and get adequate numbers of patients in trials to help sort through this. There has been some signal that suggests that adequate lymphadenectomy is supported to try and reduce the burden of disease or identify patients who would benefit from adjuvant therapy. But essentially, and the way I look at it is, it becomes essentially a very binary option. After neoadjuvant therapy, most of the patients that I operate on have been treated with a cross-style regimen, and about 85% of those patients will still have persistent local disease. Certainly with definitive doses, that pushes treatment response to about 50%. But we have witnessed this transition to inclusion of immunotherapy rather than a watch and wait approach. I personally think that because the decision point there is disease versus complete pathologic response, it really actually does raise the question of, does your approach matter? And I can see the benefit of understanding things, but how often do we actually see isolated lymph node disease with complete mucosal response?
I just had a patient with that,
Yeah.
actually.
Sure, poke a hole in my, no.
Yeah.
I actually, in my experience, it's somewhere around the proverbial 10% of the esophagectomies. The 10% rule, right? But it actually, I'm not sure anybody has data on that. I actually tried to look. We see a fair deal of mucosal still disease, and it may not be mucosal disease, it may be intramuscular disease. If it really is a binary choice, it makes that question come down to, what operation do you feel is the safest in your hands, right? And there are pros and cons and different approaches. I typically do a minimally invasive Ivor Lewis for 1s and 2s. By virtue of where I am, I see very little squamous cell carcinoma, and we very rarely resect the proximal, particularly the P16 positive squames, by virtue of they typically have good complete pathologic responses. We often find these 85%, but that's mostly in the esophagus. And if it's very rare that it's just one or the other. And immunotherapy is so much better tolerated than adjuvant chemotherapy. I don't know whether or not there are other staging criteria or things like that we could potentially facilitate the pre-op evaluation. I think we all know that investigation into neoadjuvant therapy, as chemo IO and things like that, are ongoing. And we certainly are seeing it in lung cancer. Lana, do you have an opinion about where you think we're headed with this?
Yeah, I'm sure that we're going to have more and more trials and see the outcomes after adding it to the neoadjuvant space. And it is nice to have a study finally that gives us a positive study for adjuvant therapy with immunotherapy. It's very exciting. But I think with it, we might end up moving this more into the neoadjuvant space, and maybe continue the year after. It'll be interesting to see that data come out. But I have a personal preference of, I still think that lymphadenectomy is relevant because of those patients, like you said, that, that 10% even, where if you didn't do it, that patient had a complete response at his primary tumor, but it still had nodal disease. So that's important to know.
Right. So still take the minimum 15 lymph nodes.
Absolutely. We always shoot for 15. I think there's probably some risk to aggressive lymphadenectomy, maybe a higher risk. Thoracic duct leaks, maybe a little bit more devascularization. But, we're trying to find that inflection. And like I said, it's trying to find the right balance of what you do best and trying to help patients, because the truth is our best benefit is probably getting them through an esophagectomy without major complications such as a leak. I am kind of curious to see whether or not the neoadjuvant immunotherapy has the same kind of effect. The initial data from 816 looking at pulmonary resections was a much higher thoracotomy rate after neoadjuvant therapy. The pulmonary hilum, though, is such a different space than around the esophagus. So much like the article that came out about 6-8 months ago talking about the safety of minimally invasive approaches after prolonged periods following radiation, I'm hopeful that it still looks like we can still extend a benefit of minimally invasive surgery for these patients.
Yeah, I don't think we'll experience as much as what we experience in the hilum after immunotherapy in the esophagus.
Yeah. Much less bleedy things.
All right. Thank you. So let's move on to a pulmonary topic. And this is with regards to pulmonary carcinoids. These indeed fall into a controversial category given their less aggressive behavior and overall growing philosophy of sparing lung parenchyma. So Doctors Collins and Okusanya from Jefferson wrote about current management of carcinoids. So as you know, carcinoid tumors only represent 1 to 2% of lung malignancies, so it's difficult to investigate these because of the low number of cases. But because they are well differentiated in the 5-year overall survival is approximately 90%, they have a low metastatic potential. There's discussion about being less aggressive when it comes to surgical treatment. So I'll start with you, Dr. Schumacher. What is the bottom line message for extent of surgical resection for these tumors based on the author's contribution? What can you share with the audience?
Yeah, I thought Dr. Collins and Dr. Okusanya did an excellent job of reviewing the literature for this controversial topic. And basically, you could find studies either way, as often you can, when doing these literature reviews. And, there are many database studies, from SEER, NCDB, that didn't show really a survival difference. And there's some other studies that did show a slight survival advantage of doing the anatomic resection, so either a segmentectomy or lobectomy. However, you have to, be concerned of, is there a selection bias in these retrospective studies? And clearly, I think that there are. So it is hard to kind of know which one is the right approach based on just looking at the data. One comment that I think that was made was definitely there's nodal upstaging when you're doing an anatomic resection because you're able to clear out those nodes and accurately stage these patients. On the flip side, if you have a typical carcinoid, even though if you're upstaged, you're not really doing and giving them adjuvant therapy, there's no good therapies for that situation. So that also kind of the point of, do you need to do an anatomic resection? And I think what it comes down to really is one, location, size, and if you're concerned about if it's an atypical, and you don't know that till the final path most of the time, I do feel that you need to look at an anatomic resection for those patients because they may be the ones that would have some benefit from adjuvant therapy. So it is important to have the, anatomic resection and nodal clearance for those patients. So, we don't have all the answers. A lot of what our surgery will be for these carcinoids depends on, one, the size, and two, the location. If it's central, you may not be able to, do a lesser resection, like a sleeve lobectomy. So that really is, I think, what it comes down to. If you have a small peripheral lesion, I think most people would favor you could wedge those. a little bit more central. If you want to have a clear margins, you might need to do a segmentectomy. And again, quite central, you may need to do a lobectomy. So I think that there's a lot of factors that go into the decision making of how to treat these patients. But it's good to know, even at the small peripheral lesions, I don't think that really matters if you're doing a wedge or a, anatomic resection on those patients. If we do, a large multi-institutional study, we are seeing more of these because of lung cancer screening, nodule programs, all of that are now being created. I think that we'll gain more insight on the management probably in the next 10 years, but it'll be a while.
I do think endobronchial carcinoids and parenchymal carcinoids are slightly different beasts, personally. And Dr. Schumacher was referencing that with location. And it really does dictate things. And we do have a little bit more we're going to the operating room with diagnoses more often now. So it'll be interesting to see. And it would be interesting to look at this because they do seem to be quite prevalent. That 2% does not seem to apply to our practice.
All right, so we're going to wrap it up just with bringing it back to you two and your practices. Since several of the authors wrote about lung cancer management, which is just evolving in such an exciting way, we'll all agree about immunotherapy, targeted therapy, sublobar resections, SBRT versus sublobar resection for high-risk patients. Can you briefly each outline how lung nodule cases are managed at your respective institutions after they are identified on screening and are suspicious for malignancy? Like, when does it become a multidisciplinary approach before a patient gets any sort of diagnostic evaluation? Let's start with you, Dr. Schumacher.
Yeah, so what we have at our institution is a nodule program that I think runs quite well. And it's a multidisciplinary program which allows any positive screening findings of a nodule greater than 8 millimeters or any incidental nodule that's found can be sent to this program. And it's a really nice way to capture the patients and have them be followed and take the onus off of whatever primary care physician or ER physician or whatnot that has found these nodules incidentally, or even a primary care that's been ordering the screening. So in our group, we have the thoracic surgeons, medical oncology, radiation oncology, interventional pulmonary, and thoracic radiology, all at a conference. We meet weekly and we discuss these cases. And we kind of rotate who's covering this. And we decide, at that point, who is going to manage these patients for the next steps if they need biopsy or continued surveillance. And that in that group, it's nodules less than 2 centimeters. So anything that's larger than that, then we refer to our multidisciplinary thoracic oncology group, where the patients will meet with a thoracic surgeon potentially, unless they have metastatic disease, oncology and radiation oncology, to decide kind of next best steps, biopsies, et cetera. Are they going straight to surgery? Or are they going to need, SBRT, depending on their risk stratification? So there are lots of discussion, and I think that's very valuable, especially with, newer treatment regimens, Checkmate 816, all this targeted therapy. I think all of this is very important to be managed at a multidisciplinary group.
Yeah, before any other interventions have begun. Yeah, Dr. Griffin, can you just summarize how it's done at your institution?
Yeah, we are unfortunately a little less sophisticated. We have nascent efforts at replicating and working on that. We're currently trying to work on automated nodule detection and reference referral for high-risk nodules. We're obviously working on improving our lung cancer screening penetrance through computer models and word of mouth, and doing that, we recently have incorporated our colleagues from interventional pulmonology into our office, but we haven't gotten to the point where we can have a true multidisciplinary discussion short of a tumor board or treatment planning conference type position. And that is ongoing. We, like I said, are a little bit behind, but the efforts are ramping up, and we are hopefully going to have something similar. Where I am personally, they're working on a cancer center where we can have these kind of clinics. We just physically don't have those locations as of yet. But I think it does highlight the importance of cross-specialty, multidisciplinary type treatment and make the barrier to entry into these programs quite low. And just do what we can to help get patients in and sort through. And, sometimes the answer is surgery, sometimes the answer is biopsy, sometimes the answer is follow it. But just make sure that we can do it together.
Okay. I think that's the take-home message for our audience is don't, just see not that we have a lot of pulmonologists or PCPs listening, but if we did, it's not infrequent for them to see a nodule, send them for a biopsy before they've even seen a specialist. And in 2023, that's not really the best approach. I think our audience is an audience of surgeons probably appreciate that. But the flip side is it's not always the best approach just to take them to the operating room either. It has to be a group effort to optimize the care of the patient. So, and it continues to evolve and become even more exciting, I think, for those of us who care for lung cancer and lung nodules. So, well, I want to thank both of you for contributing to this issue of controversies in thoracic surgery, as well as this podcast. And I think we'll just wrap it up here.
Thank you all.
Yeah, thank you.
Thank you for joining us for our 6th Thoracic Surgery Clinics podcast devoted to controversies in thoracic surgery. The 4 articles discussed, as well as 7 others, are in the May 2023 issue, Volume 33, Number 2. The series is available for individual print or online subscriptions. Visit www.thoracic.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.